You're doing practice test questions and you see a question about a patient with type 2 diabetes who takes their medication, skips dinner because they get busy, and a few hours later they're sweaty, shaking, confused, and the glucose is 42. Now at first glance, most people immediately think, okay, that's a hypoglycemia question, but this is where board style questions become interesting, because the STEM is not really testing whether you recognized hypoglycemia, it's testing whether you understand why hypoglycemia happened. And honestly, this is where pharmacology gets interesting, because the mechanism is not just memorization of detail. The mechanism predicts the patient. Welcome to This Is Why, a show where we help healthcare professionals transform their medical knowledge from what to why, because that improves the how. I'm Dr. Busti, and today we're walking through a board-style pharmacology question that looks simple on the surface, but actually teaches a really important core concept about how pancreatic beta cells control insulin release. And once you understand that concept, you can actually answer a whole category of questions instead of memorizing isolated facts, okay? So here's the question. You got a 67-year-old patient with type 2 diabetes, developing sweating, tremor, confusion, and a finger stick glucose level of 42 after taking an insulin secretagogue and then skipping dinner. Sulfonylureas and Meglitinides can produce this early effect by closing which ion channel in the pancreatic beta cells? Choice A, sodium potassium ATPase. Choice B, sodium calcium exchanger. Choice C, ATP-sensitive potassium channel. Choice D, L-type calcium channel, okay? Now pause for a second and think through it before we break it down, okay? What I like about this particular question is that it's not really asking whether you memorized a drug list. It's asking whether you understand how a beta cell behaves. That's the deeper concept. Okay? A lot of learners try to memorize diabetes medications individually. Okay? Sulfonylureas does that, metformin does this, meglitinide does that. But when you approach pharmacology that way, everything starts to potentially blend together, especially early on in your training. Instead, think about what the beta cell is trying to accomplish at some level. Its entire job, guys, is to sense the presence of energies, availability, and decide whether insulin should be released. That means that the beta cell has to convert a metabolic signal into an electrical signal that then converts that electrical signal into a release of a hormone. That sequence is real, and it's the teaching point, okay? And clinically that matters because these medications can force insulin release even when the patient is not eating. And that's exactly why the patient became hypoglycemic, isn't it? When I see a question like this, I start with the patient, not the answer choices. Sweating, we got tremor, okay? We got confusion, and a glucose of 42. That's clear patterns of association for hypoglycemia. And then the STEM tells us that the patient took an insulin secretagogue. Probably words you don't typically like to use, but that word alone should narrow your thinking dramatically. A secretagogue, as we all know, is a medication that stimulates the insulin release from the beta cells of the pancreas. So now the question becomes, what normally triggers insulin release from that beta cell? Okay? And that's the pathway you want to reconstruct in your mind. And this is where students sometimes move too quickly, okay? Now the first thing that I want to do is, let's just get oriented, anatomy, right? So we've removed the stomach. Normally the stomach sits in front of the body of the pancreas, so the pancreas is literally sitting behind the stomach itself, and you can see the cross section right here where it was removed. You could see where the blood supply is feeding the pancreas. You can see the pancreas is emptying its contents into the small intestine along with the common bile duct at that point, right? It merges at the ampulla, evader, and empties in the duodenum, okay? But let's zoom in a little bit closer on these pancreatic beta islet cells. So we see that when glucose is present, that is the beginning of the stages that obviously initiate the cascade for insulin release, but calcium's involvement is towards the end, okay? Now there's something really important happening here. There's a lot of things happening inside of a beta cell, but one of them is that as long as potassium is leaving the cell from the ATP-sensitive potassium channel there, as long as it's leaving, the cell is electrically stable or neutral. What's partially regulating that are the concentrations of ATP. So when glucose shows up and enters the cell, the ATP-ADP ratios start to change. And what that does is it changes the activity of that potassium channel. It shuts it down. And that's the same thing that like a sulfonylurea would do, okay, or a medication like that. It would, and what happens is that results in the depolarization of the beta cell. That causes calcium to come in, and as the calcium moves in, it facilitates the exocytosis of basically insulin into the bloodstream. And so in the presence of glucose-dependent insulin release, that is the main mechanism. But this is the channel that is being targeted by secretagogues. Okay, so the important clinical insight in this, right, is that these medications do not simply just lower the glucose in some abstract way. They stimulate insulin secretion whether the patient ate appropriately like they're supposed to or didn't. Okay? And this is why missed meals become dangerous with this class of drugs. Now, think about the patient, you know, that we're dealing with in front of us and in this case, right? The medication is still pushing insulin release, but the patient never brought glucose into the system because the dinner was skipped. So insulin activity and glucose availability are no longer matched. That mismatch is the real problem, isn't it? Now, let's look at it why the wrong answers are attractive, because this is where that board style questions really get people mixed up, isn't it? The sodium potassium ATPase pump sounds very tempting because ATP is in the name, and a lot of students have seen ATPase before for various areas of pharmacology. But sodium potassium ATPase should immediately make you think of digoxin in cardiac related physiology, and that's completely a different mechanism, isn't it? Same thing with sodium calcium exchanger, and again another cardiac pharmacology distractor. Those two answers are basically trying to lure you in to confusing you from cardiology to an endocrine physiology together, and that's what messes people up sometimes. Now that L-type calcium channel is trickier. That distractor works because calcium really is important in insulin secretion, isn't it? Right? But the question is asking which channel the medication is closing. The drugs are not closing calcium channels, right? They're closing potassium channels. So calcium entry happens downstream after depolarization. And honestly, this is one of the biggest mistakes learners make in mechanistic related questions. They recognize a true statement somewhere in the pathways or options, and they attach to it at the wrong step, okay? The reason I like this question clinically is because it teaches more than just an exam strategy. It explains the real patient risk if you understand the concept. Sulfonylureas and Meglitinides still matter because they can absolutely cause clinically significant hypoglycemia. We see that. And patients who get in trouble often are the exact patients that you would expect, right? They're older patients, patients with inconsistent oral intake, patients with renal impairment where some of these drugs are renally eliminated, right? Patients who accidentally take their medication twice. Patients who become sick and stop eating, right? Mechanism predicts the vulnerability. And this is why understanding physiology is so much more powerful than memorizing side effects. If you understand that the drug is pushing insulin release independent of the food intake, then the risk of hypoglycemia suddenly makes complete sense, okay? Now, you no longer have to memorize it. You can reason your way through it, okay? There's also an important kind of toxicology connection here, isn't there? People sometimes think that correcting the glucose fixes the entire problem. That's not the case. But with sulfonylurea-induced hypoglycemia, recurrent hypoglycemia can occur because the medication can continue to stimulate insulin release. And that's why recurrent monitoring matters, and more important significant cases like toxicology may include Octreotide to suppress further insulin secretion. And again, the treatment strategy makes more sense once you understand that underlying original mechanisms, okay? Now, if you want high-yield strategies for questions like this, try to stop memorizing isolated buzzwords that can sometimes trap you. Instead, train yourself and reconstruct the sequence. Understand the core concept, because then you can answer any question given to you. What is the cell trying to do? What changes electrically? What ion moves? What happens next? That approach works not only across physiology, pharmacology, cardiology, but neurology and endocrinology as well. And honestly, that's what stronger test takers do differently. They do not memorize more facts. They organize facts around mechanisms. That's the real goal, not memorizing disconnected details that get lost. Understand the system well enough to answer the question, and it almost becomes predictable, okay? Now, if this episode was helpful to you in connecting that physiology with real clinical reasoning, make sure to please stop and subscribe to This Is Why. Give us a like, leave a note, comment. We really appreciate that. And if you're preparing for board exam or your course exams and you need practice test questions, remember that getting better at exams is not about memorizing longer lists. It's about recognizing patterns and understanding mechanisms deep enough that you can reason through unfamiliar questions. So you have to practice doing what is sometimes expected of you. Most of those are multiple choice questions, and that's why I created and started High Yield Med Reviews. You can also get a free membership and benefits at thisiswhy.health, but you also get a discount at High Yield Med Reviews when you join, okay? So you can just go to thisiswhy.health and get there. All right, guys, I'm Dr. Busti, and I'll see you on the next episode. Keep learning the why.